Hello, my name is Mary Renju. I'm one of the junior doctors at City and Sandmill Hospitals. Today I'm going to be giving a presentation as part of the medical mini-series on a very important topic within ophthalmology, age-related macular degeneration, which I'll be referring to as AMD throughout this presentation. This slide highlights what we'll be covering in the session. I'd encourage you to revisit the slide at the end of the presentation and check that you have a good understanding of the above points. Now, as the name suggests, macular degeneration is a disease of the macula. So let's take a few moments to remind ourselves what this is. The macula is an oval area near the centre of the retina. The retina is at the back of the eye. This is what we see during fundoscopy. The inner layer of the retina contains ganglion cells, which synapse with bipolar cells. These then synapse with rods and cones, which are photoreceptors. The outer layer of the retina is one cell thick and called the retinal pigment epithelium. Rods are very sensitive to light. There are hundreds of millions of them in the eye. Cones are less in number, about 6 million. These are mostly in the macula. These are less sensitive to light but can detect colour. The fovea is a central part of the macula. This has the highest concentration of cones and provides maximum visual acuity. The macula is key for central vision. It allows us to see in detail and is important for tasks such as reading, driving, and recognising faces. Let's briefly go over the macular layers. So here we have a cross-section of a normal macula. We have photoreceptors, the retinal pigment epithelium, Bruch's membrane, and then the choroid. The choroid consists of blood vessels. This is how the macula receives nutrients and oxygen. Now, if you learn these basics, it will help in understanding the symptoms, diagnosis, and management of AMD. Okay, let's move on to the specifics of AMD. AMD is a chronic condition. In the Western world, it is one of the leading causes of blindness in the elderly. We can classify AMD into two groups, dry and wet. This is an important distinction to make as your management will differ accordingly. Let's start with dry. In an aging eye, breakdown of extracellular matter and debris from the RPE deposit in Bruch's membrane. This is known as drusen. This blocks the blood supply to the retina, resulting in areas of atrophy. Dry AMD accounts for 90% of cases. Wet AMD is more severe but less common, only accounting for 10%. It is characterized by neovascularization. This leads to hemorrhage and ischemia. As it progresses, scar tissue develops, which can permanently damage the macula. In contrast to dry AMD, the wet type deteriorates rapidly and can cause blindness in weeks. Dry AMD can progress into the more serious wet type. With increasing deposition of drusen, you get inflammatory cells making their way to the retina. These cells release growth factors such as VEGF, vasculoendothelial growth factor, that cause angiogenesis, or growth of vessels. These new vessels grow into the Bruch's membrane. However, these vessels are abnormal and leak blood and fluid into the macula. Fluid can accumulate underneath the photoreceptors or between Bruch's membrane and the photoreceptors, which is shown in the image. This damages the rods and cones. Now we have an understanding of what AMD is and how it develops. Let's move on to the clinical side of it. The following symptoms can present in a case of AMD. Scotoma, a blind spot, or blurriness in the middle of the eye. Your patient may complain of not being able to see faces, And this makes sense as we learned earlier that the macula is responsible for central vision. Peripheral vision is always maintained, even at the late stages. They may also present with reduced visual acuity and colour vision as it affects the rods and cones. Metamorphopsia is a common symptom of wet AMD. This essentially means distorted vision. Patients may complain that straight things appear wavy or curvy to them. AMD is progressive. Eventually, the loss of central vision can become severe enough to be declared legally blind. So what will your patient look like? Let's look at the main risk factors. As the name suggests, it is a disease of the elderly, so age is obviously one of them. AMD in the other eye, a positive family history, and smoking are also strong risk factors. Patients with these symptoms should be referred to an ophthalmologist so they can be investigated and managed. However, as a non-specialist, there are things you can do to bring AMD higher up on your differentials list. A Snellen test will show worsening visual acuity compared to their previous result. An Amsler grid can show metamorphopsia, although these are often used to monitor disease progression from dry to wet, as opposed to diagnosis. Hopefully, when you're viewing image A, you'll be able to see very straight horizontal and vertical lines. A person with AMD will see something like image B. Fundoscopy will allow you to see the retina, but we'll come back to this on the next slide. OCT is a non-invasive method of producing high-resolution 3D images of the retina. The Royal College of Ophthalmologists guidelines state that OCT is a must for both diagnosis and monitoring response to therapy. OCTA is the newest one, and it's a non-invasive angiogram. Fluorescent angiography can be done in those with suspected wet AMD. In practice, it's only done if OCT is inconclusive or if the patient is not responding to treatment. Fluorescent angiography involves injecting dye intravenously and taking serial photos of the retina. This can show you where the blood is in the eye. In a normal one, you wouldn't see much. In wet AMD, you can see bright spots, which are areas of bleeding. IGA is similar to fluorescent angiography, but allows visualization of the choroidal circulation as well. Okay, here is a normal retina. The macula is the area that appears darker on the left. When looking at the normal retina, you should note the 3 C's: colour, contour, and cup. I'm not going to talk about this here, but it is important to learn. In this image, you can see yellow deposits around the macula. This is drusen. There aren't any signs of neovascularization or hemorrhage. This would be suggestive of dry AMD. In this image, there are patches of red, and these are hemorrhages. This is wet AMD. I'd like to add a note here that if your patient has progressed from dry to wet, you may be able to see both drusen and hemorrhages in wet AMD. Unfortunately, AMD has no cure. However, we can manage the condition to reduce progression. This differs between dry and wet, which is why it's so important to make the distinction. In dry AMD, there's not much we can do. It's useful, however, to monitor their progression with regular follow-ups and using an Amsler grid for monitoring. It's really important to factor in smoking cessation. Smoking is a strong risk factor not only for developing AMD, but for progression to wet as well. There's no hard evidence to state that oral supplements are beneficial. However, they are not harmful and patients often like to take them. The main approach to managing wet AMD is by using anti-VEGF agents. To explain how this works simplistically, VEGF proteins stimulate angiogenesis. So anti-VEGF proteins prevents this and will decrease vessel formation. This can have a positive impact on symptoms as well, as it can increase visual acuity. The injections are done intravitreally in regular intervals, so this does mean having a needle in the eye every 4 to 6 weeks. The alternative option involves lasering the eye to coagulate the abnormal vessels. Again, these options are not curative but will slow disease progression. For either types of AMD, a holistic approach is key. Losing vision is so disabling for many and frightening. Getting the visual impaired team involved to help with their home environment will improve the patient's quality of life and reduce the risk of falls in the future. They may also want to refer to support groups. Have a read through this example question. You can pause the slide if you need more time. Okay, let's go through the answers by process of elimination. Hopefully you would have immediately ruled out options D and E, seeing as this whole session is on AMD. Timolol is a beta blocker and latanoprost is a prostaglandin analogue. These are used topically as part of treatment for glaucoma. Now on the retina we can see drusen, but there's no evidence of neovascularization, there's no hemorrhage. Therefore, we can remove option B, as anti-VEGF agents are used in wet AMD, and in this example, it's dry AMD. Now, out of the 2 remaining options, the single best answer is referring to ophthalmology. Using an Amsler grid is appropriate here. However, these are used for disease monitoring normally. It's also not as important as getting them seen by a specialist. NICE guidelines state that an urgent referral, ideally within a week, should be done. In practice, they are often referred to an ophthalmologist via an optometrist. So just a really brief summary of the main points we've covered. The dry type comes on slowly. You'll see drusen in fundoscopy, and it's managed with regular monitoring and lifestyle changes. Wet AMD progresses rapidly. It's characterized by neovascularization, and the main management is by using anti-VEGF agents. Thank you for listening.